name's Ivan Wong. I'm very excited here to be here with my co-director, Dr. Kathy Cody.
Hi everyone, I'm Kathy Cody, and welcome to our 8th Dalhousie Sport Medicine virtual annual summer research night. We are so excited to have you here, and we are also very excited to give you our presentations from our current fellows in sport medicine as well as some medical students. So welcome, and we're really happy you're here.
We want to highlight some of the things that went through with our Dalhousie Sports Medicine group at first. So again, this is actually it's not quite 8th, it's 9th annual Sports Medicine Research Night. Welcome to everyone who's here. I know that we have a lot of people online right now. We do also want to make sure that you can interact here. You can actually post comments down there, and we'll be able to interact with them in the panel discussions afterwards. We also have to recognize our industry sponsors to make our fellowship possible. We have lots of companies that make this educational activity available for our fellows. Over the past year, our group has been very busy. We've published a total of 24 papers in major orthopedic or biomechanical journals. Some highlights of this include the rotator cuff management. We got 2 bridging reconstructions in there. We also have several in the anterior shoulder instability realm, where we have 9 publications. And then we have innovations in hip arthroscopy with 9 different publications there as well. Other types of highlights, Dr. Cody was promoted to Associate Professor in the Department of Surgery at Dalhousie University, so very much congratulations to her. I have recently just been promoted to a Professor at the Department of Surgery at Dalhousie University. We've successfully completed our first SHIP course. SHIP is the Advanced Shoulder International Program, originating here from Halifax. It's the first of its kind in terms of a lab and didactic session. It's a hybrid course which involved 3 different academic centers all across the country with 3 different cadaver labs happening simultaneously with a worldwide audience. So 275 unique logins as well as 61 different countries taking part in this. Probably our most highlighted publication is our randomized controlled trial study that we were able to publish and get accepted this year. It's a maximal repair to bridging reconstruction for massive cuff tears, so accepted in our top orthopedic sports journal. In fact, our surgeries have been highlighted now. We've actually been invited to give a live surgery demonstration from here in Halifax, broadcasting straight to Las Vegas for the Orthopedic Summit, 11th annual meeting in Las Vegas in December of this year. Another highlight, we've just started 2 multi-center randomized control trials with Dr. Kathy Cody being the lead site investigator for both the STAR trial and the stability trial in the knee. We have trainee award highlights as well. Dr. Johnny Reyes, one of our fellows, has won the Orthopedic Sports Medicine Fellow OSET Award. And Mr. Rylan Murphy, he's a medical student. He won the Research and Medical COA Award for Most Innovative Project. So congratulations to both of them. Our outreach from Dalhousie Sports Medicine has been quite prolific over this pandemic. I know it's been very difficult for many people, but in terms of virtually, we were actually able to present at 54 different conferences originating all around the world, as you can see through that map. Of course, we're very lucky to have a strong research staff. You can see here we have Sarah Sparavallo, our research coordinator, Lauren Jonah, G. Ma as well for research assistants and fellowship coordinators. We have Ben Hewins, Sarah Remedios, as well as Neha Katote as research assistants as well as summer research interns to make this process possible. We've performed many labs and live surgeries. You can see a list of them here. And now you can see with this pandemic, with a lot of virtual learning, we're able to do multi-screen, multitask. For example, this is one of them that we just finished doing a few weeks ago. We're able now to be able to live stream our surgery that many people want to learn, be able to show multiple views for both inside and outside, as well as show how a graft is able to be created in multiple views to make it clearer for surgeons who are not able to fly all the way to Halifax to be able to learn this type of a technique. In fact, this technique now is taken off so that people can have a cadaver lab. So this is a virtual cadaver lab where this learning surgeon was in Texas. So they would be able to create a Zoom feed. You can see the multiple camera view that we have here. And with technology of Zoom and well as other programs, we're able to overlay images or markings onto the screen to be able to describe how to do that procedure. And this is a bone block, an allograft bone block technique to get into a patient's shoulder arthroscopically. And we can overlay technical video so the surgeon can see it. And then by the end of the virtual learning session, he's able to perform this whole technique, which is quite impressive considering we've never met each other in person. Our fellows this year, you already heard the introduction from Dr. Andres Campos Mendes. He's going to be presenting very shortly that we've had. We have Dr. Reyes as well as Dr. Frederick Michael. So we'll finish this. We're looking forward to the wonderful program. We'll switch back again to Dr. Cody to reintroduce Dr. Campos Mendes.
Hi again. I'm going to reintroduce Andres Campos Mendes. So he is one of our current fellows. He is an orthopedic surgeon who is from Guadalajara, Mexico, and he's completing a sport medicine fellowship here at Dalhousie University. He received his MD degree from Tecnológico de Monterrey in Monterrey, Mexico, and he completed his residency at the Instituto Nacional de Rehabilitación in Mexico City, Mexico. Dr. Campos Mendes is most interested in joint preservation research, and he hopes to pursue a hip preservation fellowship in the future. So this evening, Dr. Andres Campos Mendes' talk will be Do Concomitant Chondral Procedures Impact Patient Outcomes Following Arthroscopic Treatment of Femoral Acetabular Impingement? Andres?
Thank you very much for that introduction, Dr. Cody. There's not anything left for me to say. I want to thank Dr. Wang for this opportunity, all of my collaborators as well, and thank you for this amazing virtual event. This study, we started this study because cartilage defects in the hip are becoming or having a common concern through the years. They can cause pain, and they are commonly associated with femoral acetabular impingement since this pathology started being able to be diagnosed more easily in the recent years. The cartilage defects have a small capacity for self-repair, and if they're left untreated, they can progress into arthritis, leading to the need of a total joint replacement. Two of the treatments that are available for this type of pathology are BSC Cargel, which is a soluble polymer of chitosan-based scaffold. It's mixed with the patient's blood, and it's implanted over marrow access holes in the cartilage lesion. Another type of treatment is microfracture, which is a deliberate penetration of the secondral bone below the cartilage defect, and it will elicit a bleeding and subsequent bone marrow-derived repair response. Our group recently published a study that compared microfracture versus Cargel. Patients who received Cargel had a lower risk to convert to joint replacement, and this prior study didn't include a control group without any chondral procedures. So we were not able to assess the progression to osteoarthritis in patients who had no chondral risk factors. So the purpose of our study is to compare the clinical and radiographical outcomes of patients who received treatment for FAI with no chondral procedures to those that received concomitant treatment for large cartilage lesions. We selected 84 patients. 42 of them had a chondral procedure. It could have been Cargel or microfracture, and 42 were our control group that only received FAI treatment. Our matching criteria was age, BMI, and follow-up, and the inclusion criteria was patients who underwent the treatment for FAI between 2012 and 2019 with IHOT 33 scores pre- and 2-year post-op. The exclusion criteria were patients who were missing these scores at 2-year follow-up. So the IHOT 33 score, outcome score, is developed for younger active patients with a hip pathology. It has 33 items which explore symptoms and functional limitations, sports and recreational activities, and job-related concerns. Our demographics were pretty similar in age, sex, side, and BMI, so there were not significant differences between them except for the time after surgery. there was a significant difference in conversion rate to total hip arthroplasty when we broke down the chondral group into microfracture and cardial. When we compared non-chondral versus microfracture, the difference was significant. It wasn't significant between cardial and non-chondral, and it wasn't significant either for microfracture versus cardial, most likely because of the sample size. Sorry. When we did our radiographic assessment, our chondral group had a lower pre and post-operative joint space compared to control group. Microfracture group had the smaller average post-op joint space than both control and cardio group, and this was significant, as you can see. Also, when we compared our IHOT-33 scores, we also broke down microfracture and cardial, our chondral group, and by doing this, we could see there was a significant difference between microfracture and cardial and non-chondral. When we did not broke down our groups, chondral and non-chondral had no significant difference. So our chondral procedures group overall had a higher conversion rate to THA compared to our control group. Our non-chondral or control group had a conversion rate of 2.4% versus chondral group 11.9%. On our previous study from John et al., microfracture showed a conversion rate of 34%, way higher, and cardial group showed a conversion rate of 5.9, similar to the one in our study. When comparing to another study, Shire et al. In 2015 had a conversion rate of 12.4. This was done on a registry of 2 states, Texas and Florida, and it has 7,000 patients that were added to the registry. Our chondral group also showed a narrower joint space pre and post-operatively. Specifically, microfracture group had a smaller average post-op joint space. In our previous study, cardial implantation decreased the rate of progression in joint space narrowing compared to the microfracture group. Also, our outcome scores, they were improved for cardial and control groups, as mentioned before. In other studies, Tahun et al. Conducted a prospective case series using cardial for acetabular defects. The hip outcome score showed significant improvement both overall and for the sports part of the score questionnaire at 24 months follow-up. Also, Stanish et al. Reported a significant improvement in WOMAC index score with cardial application for chondral defects in the knee. In conclusion, there was a significant difference when we compared joint space and conversion to total hip arthroplasty. When we compared patient report outcomes for both our groups, there was no impact between them. Thank you very much.
Thanks so much, Andres. That was a great talk. So just before we get any questions, how might a bioscaffold like Cargel decrease the amount of joint space narrowing?
When we apply the bioscaffold into the chondral defect, the scaffold itself promotes bone marrow cells to come and implant in the defect and create more fibrocartilage, which is biomechanically not as good as hyaline cartilage, obviously. But when we don't do cardial and just do microfracture or don't do anything, we don't have this response. So most likely the defect will keep growing or will bring repair tissue or fibrous tissue, which is biomechanically has less properties than even fibrocartilage. So the defect is most likely to keep growing and to keep progressing into OA compared to cardial.
Okay, and we do have a question from Sarah. So she said, how do you think the matching could be improved in your methods?
Well, we broke down our chondral group a lot into microfracture and cardial, as you were able to see. So by creating a new study where we do 3 different groups, non-chondral, cardial, and microfracture, and increase our sample, we will be able to have better results for sure compared to what I presented today.
Okay, great. John, do you have any questions for Andres?
Yeah, Andres, why did you choose total hip arthroplasty? I'm a bit surprised, given your young age group, that there were even in the non-chondral group, so basically your control, where they had normal cartilage, I assume, and it was just FAI, that even somebody as young as average age 39 converted to a total hip arthroplasty. Why did you use that as your main outcome measure?
Well, we were concerned of chondral defects above 4 square centimeters of size to progress rapidly into OA, to a moderate or severe degree of OA. We studied these groups for 2 years, and we could see the conversion rate, as I show you, is it could be 11, between 7 and 11%, depending on the chondral procedure that we did. So we want to see how much cardial can prevent OA or total hip conversion rate, total hip replacement conversion rate for these patients. But yeah, the sample is young, but they even though they are young, we could see that the chondral defect correlated with progression to OA.
Do you think it's possible? Do you think it's possible that the microfracture actually made the OA worse and increases the chances of total hip arthroplasty? Because there is some theories in the knee, where the joint forces are not as significant, that microfracture can cause collapse and worsening of OA and even decrease the time to total hip arthroplasty. Is it possible that microfracture actually can make these patients worse?
Well, I don't think I have a good answer for that. I myself personally don't believe microfracture could worsen OA in that due to that. I think it could, just because it didn't work or didn't bring the repair tissue to the defect, and OA kept progressing, but I don't think microfracture.
Perfect. I get to introduce Alex Harper. He's from St. John, New Brunswick. He graduated from Dalhousie with a Bachelor of Medical Science in 2020. There he completed an honors project with myself in the Department of Orthopedic Surgery. Between his undergrad research and volunteering as an athletic trainer with the Dalhousie women's hockey team, he fell in love with the world of sports medicine. So Alex is just finishing up his first year at Dalhousie Medical School and hopes to pursue orthopedic surgery with a focus in sports medicine in the future. Alex?
Thank you very much, Dr. Wong. Thank you very much for everyone putting this on tonight. So as a quick background for this project, with the shoulder joint having the greatest degree of motion of any joint in the body, it's also the most frequently dislocated, with the majority of which being in the anterior direction. As the humerus crosses over the shoulder joint, it causes progressive damage to that bony anterior rim of the glenoid cavity, which creates significant instability for the patient as it helps keep the humerus in place. And then significant bone loss on CT and clinical instability are indications for surgery to address that bony pathology. And there are various procedures to do so, but in 2015, Dr. Wong and Dr. Urquhart developed the Arthroscopic Anatomic Glenoid Reconstruction, or AAGR. This technique has been shown to be a faster surgery, carrying a shorter learning curve, and has better practical results compared to the previous gold standard, which is the arthroscopic Latarjet. This technique also addresses the soft tissue damage of the labrum as well. That typically comes hand in hand with bony defects by combining it with Bankart repair for added stability. It uses a distal tibial allograft acting as a physical barrier to the humerus crossing over the joint, which must be fixed to the damaged native glenoid. Currently, there's no gold standard fixation technique of that bone block, and it's often decided by surgeon preference. Screws have traditionally been the most common method, providing a much more rigid hold of the bone block onto the glenoid rim. But depending on the orientation of the screws, complications can arise from shoulder impingement, leading to osteoarthritis. As well, graft malpositioning, fractures, or non-union to the native glenoid have been noted. Failure of the hardware itself, screw bending, loosening, or breakage are also screw-related complications. And as the graft naturally resorbs in order to match the contour of the glenoid cavity, the screws can protrude, leading to pain and potentially warrant follow-up surgeries. Suture button fixation, on the other hand, although being a less rigid hold of the bone graft, has been shown to have predictable healing and proper graft positioning. And as well, it avoids reoperation for screw prominence and decreases the complexity of future surgeries. For our study in particular, the purpose was to compare the learning curves, both in terms of surgical time and accuracy in graft placement between the two fixation methods for surgeons learning the AAGR technique. It was hypothesized that surgical time and accuracy in graft placement would be similar between the two techniques. Our study was a retrospective patient chart review, where the screw cohort were the first set of consecutive patients between 2012 and 2015, when the AAGR technique was initially developed. Similarly, the suture patients were the first set of consecutive patients following the development of the suture technique between 2018 and 2019. And then additionally, 16 patients from the same time period as the suture procedures were included for surgical duration analysis to account for the potential confounding effect of the increased surgical experience. To evaluate the learning curve, duration of the surgery was recorded and compared between techniques, where a shorter surgery is more favorable for both the patient and the surgeon. As well, variability in those surgical times themselves were assessed using the Levine statistical tests, with a lower variability, meaning more consistent surgical times and more advanced learning of the technique. To analyze the practical results of learning, 6-month post-op CT scans were reviewed for accuracy in graft placement. Panel A here depicts the vertical graft positioning, where placement below the lower portion of the glenoid, below that blue line, is the ideal location to recreate the shape of the native glenoid. Panel B shows the obliquity of fixation with an angle of 10 to 15 degrees being ideal between the green line, that fixation axis, and the blue line, the glenoid fossa axis. And then panel C shows horizontal graft placement, where green shows a medial step formation and blue shows a lateral step formation, with flush being ideal, but 1 to 2 millimeters in the medial direction is acceptable. So although the suture button fixation method was shown to be significantly faster than the early screw group, the increase in surgical experience between the early screw group and the suture button fixation group may have been a contributing factor to the difference seen, where the late screw group was also significantly faster than the early screw group. In the comparison between the suture button group and the late screw group, no significant difference was found, showing that the surgical times and learning curves are comparable. For vertical placement, no significant difference was found between the techniques, showing that the suture fixation technique retains accuracy of graft placement in the vertical direction. And then in terms of obliquity, the overall mean was significantly smaller in the suture button group and remained within the ideal range of 10 to 15 degrees, while none of the screw cluster means fell within this acceptable range. And then finally, for the horizontal placement, although the screw fixation group had a significantly smaller step, both the screw and button fixation groups remained within this acceptable range clinically. So what's this all mean? Suture button fixation is just as fast and easy to learn as screw fixation, which has already been shown to be faster than other surgeries that address bony pathology. And suture fixation does not compromise optimal graft placement. Ultimately, fast and consistent surgeries are more appealing for surgeons learning to adopt the AAGR technique. And the next steps for the research would be to compare the patient outcomes in terms of short-term and long-term, both clinical and radiological, and then to increase the study size as well. So thank you to everyone who helped me out today, and I'd be happy to take any questions.
Great. Thank you very much. John, do you have any to start?
Yeah, that was a great presentation, Alex. You didn't discuss any complications. Was there any screw breakage, any graft resorption, any complications between the two groups?
Yeah, so that's exactly kind of what I was getting at the end there. We haven't actually studied the outcomes of these surgeries as of yet. Preliminarily, they look fairly good, but again, that is something that is kind of coming down the road. This was just kind of a learning curve analysis for now, and then that'll come.
And is there a cost difference between the two?
Once again, probably shooting above my pay grade here because I'm not really there yet, but I'm not entirely sure.
The buttons are probably more expensive, right? Like those type of implants are generally more expensive than screws. So maybe looking at cost effectiveness, but obviously decreasing surgical time, that costs money, although, maybe the OR doesn't care about that, but they care more about the cost of implants or the people in charge, but it is something to look at as well.
Oh, great. Yeah, there's a question from Lauren. Do you see that on your screen too?
Oh, yeah. So why is it important that surgery is shorter? So just as John was just mentioning there, kind of comes down to cost effectiveness, where a shorter surgery means that the patient would require less medications, less anesthetics. So come down to less cost to the healthcare there. Then for the surgeon themselves, shorter surgery would mean that they can see more patients in the run of a day. They can get other aspects of their job done. And then for the patient themselves, a shorter surgery carries less risk for surgical site infection. So for patient outcomes themselves, but also they would require less antibiotics. And so again, less cost for the healthcare as a whole. But yeah, so it comes down to really cost effectiveness.
Great. Thank you very much. We'll move on to our next speaker.
So welcome to our next speaker, who is Zach Ali. He's from Toronto, Ontario, and he's recently graduated from the Royal College of Surgeons in Ireland. He's been involved in orthopedic research for several years in Canada and in Ireland, and he previously worked with Dr. Wong's team on their economic analysis of the arthroscopic anatomic glenoid reconstruction procedure. Since his talents didn't really translate on the ice, Zach is interested in pursuing a career in orthopedics and sport medicine, and he's currently working towards obtaining a residency position for 2022. So welcome, Zach. And Zach will be talking about assessing the correlation of postoperative graft status and postoperative outcomes in arthroscopic bridging reconstruction for massive rotator cuff tears. Go ahead, Zach.
Today, I'll be discussing postoperative graft status and its relation to the clinical outcomes following arthroscopic bridging reconstruction for large and massive rotator cuff tears. So to start off, rotator cuff tears are one of the most common injuries of the shoulder and can result in patients experiencing significant pain, loss of function, and decreased quality of life as a result of one or more of the four rotator cuff muscles being torn. These tears are classified according to size. So for large size, that's above 3 centimeters, and massive tears are considered above 5 centimeters. So traditionally, the gold standard of operative management for larger tears has been maximal repair, in which the surgeon aims to create the rotator cable to restore function by creating a suspension bridge. However, due to historically high re-tear rate, surgeons have looked to alternate techniques in an effort to better manage these tears. So one of these techniques is arthroscopic or bridging reconstruction, which offers a more anatomic procedure and aims to recreate normal cuff tissue, allowing for more dynamic stabilization by using the cuff remnant to regain the normal cuff biomechanics. So if you look at the picture on the bottom right, you can see the yellow rectangle. So that represents the graft and connecting the torn cuff to the bone tuberosity. So Dr. Wong recently conducted his randomized control trial, which looked at the repair using arthroscopic bridging and using dermal allograft compared to maximal repair. And he found that dermal allograft reconstruction demonstrates more favorable healing rates compared to maximal repair. So dermal allograft is one example of a graft that may be used in bridging and is a skin graft that is sutured into place between the tuberosity and the cuff remnant. So recognizing that there was a gap in the literature, we looked to assess if the postoperative graft status correlates with the patient outcomes following bridging reconstruction. So we retrospectively reviewed all patients who had bridging reconstruction with a minimum of 2 years follow-up. And the outcomes measures that were used were the work score and DASH score primarily. And these are two examples of questionnaires, kind of like how you heard in the first presentation with the IHOT score, that look at the patient's symptoms and function and generates a score correlated to that. So for example, the work score, which is what we focus on in the study as it's specific to the rotator cuff, that score is created by evaluates 5 patient domains. So the patient's physical symptoms, there's sports and recreation, work, social function, and emotions. So in total, 51 patients met the inclusion criteria. And using their postoperative MRIs, they were categorized into the healed, partial tear, and complete tear groups in accordance with their graft integrity. So in our population, we have 34 patients with healed grafts, 12 that had partial tears, and 5 that had complete tears. So when we looked their outcomes at the 2-year mark, we saw that patients with partially torn grafts and healed grafts had statistically significant improvement in their outcomes compared to preoperative. And meanwhile, patients that had completely torn grafts did not exhibit a significant improvement in their patient outcomes. We also looked at the minimal clinically important difference, or MCID, which is essentially a numerical barrier that shows whether the patients have enough improvement in their outcomes to be considered significant. So in the work score, that is considered a 15-point improvement, or a decrease by 15 points from their preoperative score. So when we looked at this, we found that the patients with healed or partial tears met the MCID significantly more than those with complete tears. And you can see that by the graphic in front of you. all the patients in the healed group, all 34 met their MCID. Meanwhile, those numbers decreased as you go down to complete tear. So just some points of discussion. Well, the most important finding of our study is that partial tears perform similarly to those with complete tears. Currently in the literature, there is ongoing debate regarding the clinical effect of rotator cuff retear. And just looking at this, we have two contrasting studies, both of which look more at maximal repair, but their results can be inferred here as well. So on the left, we see the systematic review of rotator cuffs prior to 2012 by McIlvaney et al., which suggests that outcomes of rotator cuff repair will improve regardless of the cuff integrity postoperatively. Meanwhile, the meta-analysis by Yang et al. On single versus double row repair suggests that full thickness retear will result in poor outcomes regardless. And while these don't have a focus on bridging, our results do kind of match the second study, which suggests that full retear does in fact result in poor outcomes compared to partial and healed grafts. So the next point, as I alluded to in the method sessions, there's some different outcome measures that can be used. And we obviously emphasize the work score. And we think this is important because it is important to focus on pathology-specific outcome measures as opposed to general regional scores, as they're more impactful in assessing these patients' outcomes. Lastly, our results from the 2-year follow-up, the 2-year follow-up is still considered a relatively short amount of time. And it would be interesting to assess these patients at longer follow-up points to see if the graft integrity and or outcomes are maintained over time. And this could be an opportunity for future study. So in conclusion, partial tears perform similarly to healed grafts, and complete tears do not show significant improvement compared to preoperative outcomes. So what does this mean clinically? It kind of raises the question that have partial tears sort of been miscategorized. So if we look in that there are studies that have that discuss retear, and they typically separate out their findings into torn and healed groups, which thus includes the partial tear population in the torn group. And this data suggests that the partial tear may be miscategorized when you put them in the torn demographic, as we see that their outcomes do perform more similarly to healed grafts. So bearing this in mind, surgeons may be able to have a different expectation for these patients moving forward. And again, this could be something to assess further in future study. So thank you very much for listening today, and I gladly answer some questions.
Great talk, Zach. Thanks very much. Why do you think partial tears are doing just as well as the healed grafts? What do you think's going on there anatomically to account for this?
Sure. So I think anatomically, we see that when you have the graft, if it's a partial tear, the connection from the existing muscle to the tuberosity is still there. However, when there's a complete tear, there's no more connection to the muscle itself. So as a result, even though there are some small tears in the partially torn grafts, there is still the connection that allows for some function.
Okay. All right. John, do you have any questions for him?
Yeah. What did you define as a complete tear? These grafts are attaching what to what? I'm a little bit confused as to what you define. Is it tearing off? It's attached to the subscap, to the posterior cuff, to the glenoid, to the humerus.
Sure. So my understanding was that it is connected to the tuberosity of the humerus. All these were read by one of the radiographers, and he kind of assessed whether they fell into the partial tear category or the complete tear category.
Okay, that's great. Well, thanks so much, Zach, for your presentation. That's great.
Thank you.
So our final research presentation tonight will be from Dr. Johnny Reyes. So Johnny is an internationally trained orthopedic surgeon currently completing his fellowship in sport medicine at Dalhousie University. He earned his MD degree in orthopedic and a specialist degree in St. Joseph University in Beirut. And he did additional postdoctoral training in arthroplasty and trauma in Diderot University in Paris. He previously completed a clinical and research fellowship in knee arthroscopy at Santi Orthopedic Center in Lyon, France. Dr. Reyes is interested in research focusing on joint preservation techniques in the shoulder and hip, as well as ligament reconstruction in the knee. So welcome, Johnny. talking about, do 3D models used during preoperative planning help improve CAM resection in the arthroscopic treatment of femoral acetabular impingement? Welcome, Johnny.
Good evening, everyone. Thank you, Dr. Cody, for the presentation. I have no disclosures, and special thanks for the research team who helped me to achieve it. So, as introduction, hip arthroscopy has been rapidly evolving, and the most common surgical indication is FAI, or femoral acetabular impingement. As its name indicates, FAI is an impingement between the femoral head and the acetabular socket. Most of these cases are related to the presence of what we call a CAM deformity in the femoral head, which we can see on this view. Normally, the femoral head resembles a round ball that can freely rotate inside the pelvic socket without any impingement. In case of CAM deformity, there's often impingement beyond 90-degree flexion, and this is correlated to growing pain on physical examination with flexion, adduction, and the internal rotation typical test. So the objective of hip arthroscopy is relatively simple, and is to make the femoral head round to eliminate any impingement. Now, how do we define the CAM? The most common used measurement is the alpha angle. So the alpha angle is the intersection between the femoral head neck axis and the junction between the femoral head and the femoral neck. And in a normal hip, usually this angle is below 55, and the CAM is defined. Most surgeons agree that it is typically equal or above 55 degree, as we can see in the hip in the right X-ray. So the objective may be simple, but the surgical technique is not easy. To date, 20% of patients after hip arthroscopy go on to undergo reoperation, and almost 1/3 of patients will end up having osteoarthritis in the early years after surgery. And the most common cause for this is the persistent CAM, as we can see here. Usually the CAM will be convex, and a good resection will have a concave connection between the femoral head and the femoral neck, as we can see in the below picture. So to achieve this, preoperative surgical planning is key to accurate resection, because understanding everything during the hip arthroscopy can be difficult sometimes. So to do this, originally only X-rays were used. And because the CAM is a 3-dimensional deformity, at least 3 X-rays were used. And these are often the AP view, as we can see here. And this can give us an idea about the lateral CAM, highlighted by the white arrow. And we have the frog leg view, and this is a lateral view, like a strict lateral view. And we can assess the anterior CAM. And the most common known view is the Dunn view. And we can assess the CAM in between, or interlateral CAM. Recently, and the gold standard for surgical planning is the CT 3D reconstruction. And here are some views that correlate what we can see on the X-ray and the AP view, and if you look directly on the 3D view, as well as a correlation between the two lateral view, as we can see here. So it helps us to assess more the 3-dimensional deformity. And recently, 3D printed model, as we can see here, has been emerging, and their use has been effective in pelvic fracture and scoliosis fracture, but their importance in the hip and CAM resection has never been evaluated so far. More importantly, these models can be used before the surgery and during the surgery. And this is what I've been doing for the last few years. The model would be in front of us while we do the hip arthroscopy, and this will help to detect all the zones that we can miss. So the purpose of our study was to compare the postoperative CAM resection quality in patients who received conventional surgical planning with those who received the 3D model in their planning. And our hypothesis was that 3D model would be beneficial. So we included all our patients from 2015 to 2019. We assessed CAM patients above 55 degree, and after application of the exclusion criteria, we had 159 patients in our study, and 88 in the conventional CT group and 71 in the 3D model group. So we did only this angle before and after surgery, the alpha angle that I already talked about. So we wanted to assess the quality of resection, and this is why we chose 55 as a threshold. So patients were categorized to good resection if they have less than 55 on all 3 views, and poor resection if they have alpha angle of more than 55 on at least 1 view. So these are our numbers. Basically, both views showed the improvement in both in resection before and after surgery, as we can see between the numbers 65 before surgery and 52 compared to 65 to 47. And these were right for all 3 X-rays. but the 3D group showed higher quality of resection, as we can see lower number of alpha angle in the 3D model compared to the conventional group. And when we categorize our patient, this is and when we look at each X-ray alone, we had higher resection quality in the 3D model group and less resection quality also in the 3D model group compared to the CT scan. And this was also correct for the other two views, the frog leg and the AP view. And this is an example of the poor resection. We can see the cam still here, and this is a normal hip of a good resection. So recent evidence had proved that adequate cam resection is associated with good functional outcomes. We now know that higher alpha angle, which means higher cam, can correlate with poor outcomes, and this is particularly true for the anterior and the lateral based cam mostly. So there's only one study who used the 3D hip model in the hip for cam, and it was only a survey. We can see the example of this question. So they gave it to 10 surgeons and 10 residents, and they assessed their opinion of using the 3D model before and during the surgery. And almost all agreed that it can help them to understand how to resect the cam with accuracy. So our study was the first to report on the efficacy of 3D models with the radiological parameter that proved the cam resection in FAI. So in conclusion, adequate cam resection could be achieved using both planning methods, but the quality of the resection was improved when the 3D model was used, as we had higher number of patients showing complete cam resection in the 3D group, and our hypothesis was confirmed. Thank you.
Great. Thanks so much, Johnny. Appreciate that talk. It was very informative. John, do you have any questions for Johnny?
Yeah, Johnny, we tried to do a 3D printed model of 3D CTs, and we found a lot of artifacts sometimes. Your 3D models actually look quite accurate. Do you believe that they are a very accurate representation of 3D CT, or can you get sort of a little bit of artifact depending on the quality of the 3D printer that you're using?
I agree. This is a common problem, and it all depends on the CT scan reconstruction. And usually most CT scan, when they do a 1:1 ratio compared to normal individual. So basically, when you look at the 3D reconstruction, it should be the same size of the normal hip if we're looking at it. And regarding the issue with the small problem with the model size and all these minor differences, it all relates to the program we use, because we have to use the images, the DICOM image from the CT scan, and usually we need minimum of 300 slices to have a good presentation of the 3D reconstruction that we can use in our printer. So we use the specific software. There are actually many, but the one we use named Horus, and we can actually shape it and like remove all the background noises to have an accurate recreation of the 3D model that we can give it to the printer to print it. So great. Basically, we can say it's accurate, and we've been using this for the last few years.
Great. Justin has a question. Do 3D prints help with the overall cost and effectiveness of the surgery?
I'm sorry, I didn't hear the question.
Yeah, I think he means, do the 3D prints help with the overall cost effectiveness of the surgery? Is it more cost effective to use a 3D print?
If we want to, if we have a hip we want to print, it usually costs at an average of $40 of fiber tissue. So it's not a big cost compared to the CT scan, but this is only our study now that showed that 3D models can be better than 3D CT scan reconstruction, and without having a good randomized trials to compare these, I think most surgeons will still use the CT scan 3D, probably in addition to the 3D model as well.
What we'll do is get our fellows to give their summary of their experience here in Halifax, and I have great pleasure to reintroduce Andres Campos, and we'd love to hear what you have to say in terms of your experiences here in Halifax, Andres.
I'm from this country called Mexico. Mexico is a pretty big country. It's not as big as Canada, definitely, but we are more people for sure. It's 127 million people. so pretty crowded down there. The capital is Mexico City, and there's no official language, but most people speak Spanish, and there are 68 Amerindian languages as well. Most people in Mexico are Catholic. Mexico is, to me, a beautiful country. I'm really proud of being from Mexico. And we have a shock or a cross of cultures between our past and our present and future. So we have, as you must know, pyramids and all that our ancestors left for us, but also all this architecture that was developed after the Spaniards came and conquered the lands. So there's a lot of culture, folklore, and mystery in Mexico as well. There's a lot of art, and yeah, it's a pretty diverse culture for sure. Also, while I was here in Halifax, almost every person I got the pleasure of meeting has been to Mexico, so that's a really nice experience to be told where they have gone and what was their experience down there and what they thought of it. So it's pretty nice to learn all of that from people from here. One thing I love for sure is Mexican food. When we were kids, I guess we are taught to eat spicy foods, even though we're through 2 or 3 years old. Since that age, we started eating spicy food, and by the time we are grown-ups, we cannot live without it. Like when our food is not spicy, it's as if it had no flavor. So that's pretty funny to me to realize now that I spent a full year here. Some people that are from my hometown, you may know one or some of them. Sergio Perez, Formula One race driver. Saul Alvarez, world professional boxing champion. Lorena Ochoa, top-ranked LPGA golfer. And Guillermo del Toro, Academy Award winner. They're all from a town called Guadalajara, which is the capital of the state of Jalisco. Jalisco has cities like Puerto Vallarta, which you must be more familiar with, and the town of Tequila, which tequila is originated from. This is my family, my parents to my left, who I owe every little achievement that I've got so far. My 2 sisters, who I'm pretty close with, and both of them are married and both of them have a child. It's pretty cool to be an uncle because you can be with your nephews and then they just go home and you see them the next day to play again. So that's cool. I went to medical school in the city of Monterrey, which is north of Mexico. You can see the picture of the school up there. And the hospital where I did most of my MS courses, it's called Centro Médico Zambrano Elion, or Zambrano Elion Medical Center. Most of the pictures around are from the day I graduated from medical school. Then I went to residency in a hospital called Instituto Nacional de Rehabilitación. In English, it might be translated to National Rehabilitation Institute. It's a university-based residency program from the Universidad Nacional Autónoma de Mexico, or Mexico National Autonomous University, which is the oldest and the most important public university in Mexico. During residency, I made really great friendships that I know will last for life. And I had a really amazing experience during the 4 years that I was in residency. Also during residency, I had the chance to do some courses or some clinical clerks outside of the hospital where I was in. I got the chance to go to Dallas and meet Dr. Hal Martin, who is a great hip preservation physician, and he focused a lot in posterior hip. We were able to submit some abstracts for ISHA in 2019, which was the last ISHA that it was able to happen before the COVID pandemic. I was able to do a presentation and put a poster for that meeting. Also, I had also the chance to go to San Antonio and meet Dr. Burhardt before he retired. So I'm really happy I had the chance to do that, because he's an amazing human being and an amazing physician. And yeah, I have nothing else than praise for him and for his career and what he did for shoulder arthroscopy and preservation. These pictures are from the day I graduated from residency, which was February 2020, right before the COVID pandemic struck in the Western world. So, so yeah, I was pretty, I guess, grateful that this could happen right before everything changed. A few months after this, I got the chance to fly to Halifax in the middle of a pandemic and start my fellowship with three great physicians, Dr. Catherine Cody, Dr. Alan Wong, and Dr. Nathan Earhart. My first rotation was with Dr. Cody, who is the best for knee scope and knee pathology. I learned a lot from Dr. Cody, and also from pediatric sports medicine, seeing those children and how the management changes when they're still growing, right? So thank you, Dr. Cody, for everything that you taught me. And yeah, you are amazing. I remember when I landed in Halifax, someone in the airport asked me why I was coming here from Mexico, and I told them, like, oh, I'm doing a sports medicine fellowship, and they knew like, oh, with Dr. Cody, and I was like, yeah, Dr. Cody. So yeah, everyone knows Dr. Cody. After that, I went to Dartmouth, which is called the dark side of Halifax, but Nathan Earhart, Dr. Earhart makes it a little bit brighter for sure. I had a lot of fun over there, and being there and seeing all the versatility of procedures that he does, both scoping and open. It's amazing to see him work, and to operate with him. There are times that you feel like you're in the OR with a friend. So thank you, Dr. Hart, for everything that as well you taught me, and for being so through and so thoughtful. And after that, sorry, my voice. After that, Dr. Wong was my third rotation. Dr. Wong is just an out of this world surgeon. He just does the most complicated procedures. Feel like they can be made by anyone. It's impressive to see him operate and to learn from him. It's just I cannot believe how sorry, what was the word? Sorry, yeah, translation problems. But yeah, I'm just so grateful for the opportunity I had to see him work. During this year, this was a really different year for sure. We may not have been able to have a lot of exposure to a lot of things, but we tried to make the most of it. I want to thank Johnny and Frederick, my fellows, who were great through this year, who helped me a lot and helped me grow for sure as a surgeon and as a human being. In these pictures, you can see our Rotator Cuff World Cup, which was last year. It was a lot of fun, and we also had, I was able to present at the Day of Surgery Research Day virtually, for sure, of course. Also, during this year, I had the chance to know a lot about Halifax and Nova Scotia and all the story and all the culture that it has and all the beautiful people that I met during this year. So I just want to thank everyone that I crossed paths with, basically Dr. Cody, Dr. Wong, Dr. Earhart, Pam, Michelle, Dalal, Mandy, the research team, Sarah, Ben, Sarah, Lauren, G. If I'm missing anyone, just thank you.
Andres, thank you very much. You've been a wonderful fellow here in Halifax, so we're going to miss you when you're gone.
My Halifax experience, I don't know how to compete with the Mexican culture here. So I'll take a few minutes just to introduce myself and my journey so far. So I come from Lebanon. Lebanon is the capital of the Middle East. It's a very small country with almost like 10,000 square kilometer surface. However, it is, because of its tourism and the high level of activities, has regained the name of the capital city of the Middle East. So the main attractions we have in our country that I can mention that worth mentioning to visit if you go there would be the Baalbek Temple. The Baalbek is a city that was mentioned in the Bible. We then have the famous rock, Raushi Rock. It's a 60 meter high, and divers from all over the world just come to jump over the cliff. There's a Lady of Lebanon with the amazing view over the Beirut city. And we have the famous Cheetah Grotto with its own ecosystem. So what's good about my country is the weather. Actually, because we have mountains and city are very close to each other. Like there's like in between winter and the spring, we can on the same day ski in the morning and go to the beach on the afternoon. So this is Beirut, the city that does not sleep, and they call it the capital of nightlife in the Middle East as well. And it resembles a little bit of Halifax with its waterfront. Unfortunately, you all know about the recent explosion that destroyed half of our city on the 4th of August. There are more than 200 confirmed deaths. And for those who didn't see this video, this is a live one. It was a bad experience for everyone. So I come from a small hometown called Himalaya, not Himalaya. We have snow there. And this is my family. I have 4 siblings. And we have a new member born last month. So I gained my medical degree from the St. Joseph University, which is the oldest med school in my country. And I then made it to orthopedics, and I did my 5-year residency at our university center, Hotel Dieu de France, which is affiliated with Paris, which has made me go there later on. It is the main hospital in Beirut beside the American University Hospital. So we have a complete team of pediatric surgeons, spine, upper and lower limb. So I would say I had a nice balanced experience at the end of my training. And I believe it's the same everywhere, the same hierarchy. Although it was well respected, we really felt like a family, and we used to do like every other Sunday hike with our program director because it was his hobby eventually. So I then made it to Paris for additional training in trauma and arthroplasty. I chose the Pitié-Salpêtrière Hospital because it is the biggest hospital in Europe and the #1 level trauma center in Paris. It was an amazing experience. Like we had a 24/7 emergency call. I'm sorry for these pictures. And like we received every type of trauma, and some nights we didn't have enough external fixators. So we had to improvise like these cases. And this is me on some post-weekend call. We used to do all weekend, like 48 hours nonstop. The morning rounds, all the team together to share the cases from last night. Some X-rays that I did myself during this year. Like I asked myself, was it really me? At the end, it was really unforgettable experience, and I made lots of connection. I then moved to Lyon, which is a city just close to Paris, 2 hours by train, to do my first fellowship there at the Santé Orthopedic Center. I was supervised mainly by Dr. Sandri Cote, who is a renowned surgeon mainly for ACL reconstruction. He does with 2 other surgeons more than 1,200 ACL per year, which is really an amazing number. And they had many important paper and recommendation themselves. And I was lucky to get the scholarship to pay for my expenses there, as it wasn't financed. So it was good and professional experience at the same time. I was helping this sports position for the Olympic Lyonnais Football Club, which is the main club of Lyon. And the main surgery they do there is they like to combine ACL and the interlateral ligament, even in primary surgery. So you all know that the Swiss or the French Alps are close to Lyon. It's only 2 hours by train, and I was able to to practice more snowboard and advance my experience. Then I flew from Lyon to Halifax, and from one day to another, my second fellowship began. of course, after the 2 weeks quarantine. Before I start to talk about it, I was just reviewing my notes that I submitted before I began my start. And some of them really struck me because I look now and they were really basics. Like we can see in shoulder, like I wanted to learn diagnostic scope. I can manage to learn labor repair. I said, I know the basics, watch it a few times, never tried it yet. So at the end of my fellowship now, I really know the difference of where I was and where I am now. Some of the advanced techniques I learned and that I have never done before, which is the letter J technique we use with the allograft here, glenoid reconstruction, some of rotator cuff patching, multi-ligament knee reconstruction, labor repair. So I'm really happy to know this technique and I'm really confident to start my own practice with it. Research part was very important in my fellowship and I'm very happy to assist the research team and they assisted me all the way during this fellowship. And we also, we almost we were subscribing in a fellowship series with Anna. Almost every other Tuesday we had a big conference. It was really good having all these conferences all over the year. And even though my laptop keypad crashed early on, I never stopped the research because I always wanted the sports team to be happy. So these are some published and accepted papers and we have many to come. Conferences as well. This was a good experience to me. I did a few conferences before I came here, but one of the most important one was the Orthopedic Summit. Unfortunately, it used to be held at Las Vegas, but we didn't get the chance to go there with all the team. So it was virtually, but I presented my paper and I won the best clinical paper, which is amazing to add to my CV. And this is mainly due to all the help of the research team. I couldn't have done it alone. I'm also speaking at the next ANA and the OSM meeting in July, if you will watch it. And I would just want to thank the research team. They are really professional, but more importantly, I never felt like I was only doing work. It was also always friendly and family environment. And just to introduce everybody, is the best driver in town who saved me a lot of time when I wake up late. And the fellowship really was very complete. We had many cadaver lab days and we enjoyed, we used to learn the thing we did. We never, we weren't used to it before doing in the OR. And I really thank all Dr. Wong, Dr. Cody, and Dr. Urquhart for giving us these times. This is special to the residents here. I always hear the fellows' life compared to the work the residents do here. I appreciate it, of course, but every fellow had his 5 years of suffering and residency. So just as for them. And there are some residents here that call themselves professors compared to us, humble doctors. And we even had free time to do our own competition. And unfortunately on that day I lost when I was competing with Dr. Mendez. I never forget this day. Dr. Urquhart, from the day I started, he knew I like to do snowboard, and he told me he's gonna compete with me. So we went to it was a OR day. We went to Hans, and this is him skiing, and he took a video of me just doing the basics of snowboard, just to humiliate me. But I can tell him that no matter how the difference between us, snowboarders are always coolers. Some quotes that I kept hearing them all these years is Dr. Cody. Every time I ask her a question and she doubts me, she tells me, have I been here before? I've been here once or twice. And this is Dr. Wong. Every day after every surgery, what did you learn today? The question that I never had the correct answer to it, no matter what I answered. And Dr. Urquhart it was really humble working with him. I never felt like I was an assistant. We were more like two surgeons doing a case together. And he always tell me, when I try to do it my way, you can do it on your patient, just don't do it on mine. And the staff is really amazing. We were between Dartmouth and Scotia Surgery and the HI and also IWK here at Halifax. All the staff are amazing. It was really an amazing experience. These are pictures of some of the trips we did. This is in Mahone Bay and Lunenburg. This is amazing town, amazing views. This is Peggy's Cove for those who never been to Halifax. It's a great city on the waterfront. And this, my only vacation, I took the 2 weeks to go to get married in Lebanon. It was in October. Unfortunately, I got the COVID, and basically my honeymoon was getting like it was really severe case. I got 50% of my lungs, and like my set was like this for almost a month. Then I came back here, and I really thank the support for the sports team that were really asking me daily how I feel. So I can't say except it's the best experience so far for me. And some of the research member asked me today, what are your objectives? What's your purpose? And I answered them like this: sky is the limit. And I'm heading to Calgary for my trauma fellowship next year. I thank everybody, and for all my mentors, I can tell them only this sentence: thank you.
Thank you very much, Johnny. That was great presentation, great conclusion to our night. I must say, for our first hybrid event, I think it went pretty good. Love to thank our faculty, obviously my co-fellows, co-fellowship directors, for Dr. Theodoropoulos.
And we'd like to thank, for sure, John, we really enjoyed your talk, and thank you very much for taking time out of your very busy life to join us tonight. We really appreciate it, and we appreciate everybody being here with us. We've had a great year with our fellows, and the medical students did a great job with their research paper. So we appreciate you being here, and thank you so much.
Thanks.
Thank you.
Stay safe.
Thank you, everyone.
Mm-hmm.